All right, well, good evening, everyone. I'm Dr. Simonson, one of the bariatric surgeons, and tonight's a pretty informal conference. It's the educational piece so that everybody can have a chance to see what our program's about, what the surgeries offered are about, and really what's expected of us, what's expected of you throughout the program, so that there aren't any surprises as we go along. If you haven't already kind of picked up, there are a lot of pieces to a bariatric program, and there's a lot of steps. It's not something where you just come in and say, hey, that sounds like a great idea, sign me up. And some of that's put in place by our national association, some of that's put in place by physicians themselves, some of it's put in place by insurance companies, quite frankly, that want to know that what they're providing for their patients is a good idea. Okay? So as I go through, if I'm going too fast, throw up your hand. If I need to go back through something, if you don't understand, if you have a question, go ahead and ask as we go, and I'll stop and answer questions, but certainly there'll be time at the end to ask questions as well. And then there may be some people that have questions that they don't want to ask in front of the group. I usually am able to answer some questions afterward, but more importantly, we sit down in the office and talk about anything that may be specific to you. That's really what our office appointment is about. So, as far as the surgical weight loss program, again, it's not just a surgery. It's an entire program. A lot of it is spearheaded by the National Association of Metabolic Surgery, and they put in place some of the details for our program. We are a credentialed program, and so a lot of what we do is not just something we came up with. It's been tried and proven to work in multiple programs and multiple universities, multiple hospitals across the nation. So really it's starting here, a decision to take control of your life, and unfortunately weight control is something that everybody struggles with, and unfortunately obesity has become an epidemic, so it's something that we're looking for better ways to control our lives from that aspect, and weight loss surgery is the single proven way to take control after a certain amount of weight has been gained. As far as our team, we've got Dr. Curtis and myself are the bariatric surgeons that have been here for several years since the start of the program. You may have seen in the paper the ads for Dr. Wolinen and Dr. Wiesen, our two new additions here over the past couple of months. Sarah Schaefer and John are our clinical psychologists, and if you're wondering, yeah, we do mandate that everybody go see one of the clinical psychologists, either from our team, or if they're out of town, we have to approve them so that we know that everybody's in the right frame of mind to proceed with surgery in our program. As far as the rest of our team, Celie is our clinical dietitian. Most people know Karen and Vicki, who helped check you in this evening, and Jackie, Doug, our exercise specialists. They actually have a program that we call Fit Camp, and is an integral part of kind of getting people in the right frame of mind for exercise that they can do both prior to and after surgery. And then Tanya and Jason North is a new pharmacist that has taken over the pharmacy and is really doing a great job for us. They kind of answer a lot of questions detailing specific medicines, medical regimens, what can be taken before and after surgery, if we have to do a different formulary or a liquid form of a medication, for example. They're the ones that help us with that. So when we talk about obesity, unfortunately, there needs to be a definition for every medical condition, and obesity is something that is not easy to define. When we look at it, we have to quantify it. So we look at things like, how many pounds overweight or how many kilograms overweight someone might be. That varies by height, obviously, so we put it into something called the body mass index, and that is simply weight divided by height, so that we can quantify and see how many pounds, or in this instance kilograms, overweight somebody might be for their height. If you look at the bottom, those are kind of formulations from the 50s when people were obviously shorter and quite a bit lighter, but still this formulation has kind of evolved over time to BMI, which is the standard internationally in terms of how we talk about what obesity is. Statistically, again, I mentioned that obesity has become an epidemic, and the Global World Health Organization estimates that over half of the people in the world are obese, which again, by statistical sense, it doesn't make sense that under half of the people are normal, but that's really where we've gone over the past few decades. It's shifted so rapidly that people have gained weight faster than they can really keep track. So if you look at things like this is from 2014, that's already old data and has probably shifted more. Children, unfortunately, are not exempt to this epidemic, and it's not necessarily all genetic. It's not necessarily all what they see is what they do. Unfortunately, it's a multifaceted problem, but as we get bigger, so do the children, and we're seeing a lot of obesity even in pre-adolescence. So when you look at this, 2 to 5 years of age, 12% of children are already in that overweight category based on adult standards. When you get up to the middle school and high school age kids, almost 20% are meeting that criteria. When you look at the health consequences, if you believe it or not, this is actually an abbreviated list of the health consequences of obesity. There are over 100 now. Many cancers have been, shown to be linked to obesity or being overweight. So this goes through by body system, just a few of the more well-known conditions that are tied to being overweight. And it's everything from fatty liver, which has overcome alcoholism and cirrhosis as the leading cause of liver disease and need for liver transplant. Diabetes, of course, heart disease are known, but things like breast and endometrial cancer in women and prostate and colon cancer in men are directly tied to weight issues. So if you look through there, it's again kind of astonishing that all of these things are linked to obesity. As far as medical treatments, unfortunately, there haven't been any very successful medical treatments for weight loss. If you look, it makes sense. You have a low-calorie diet, you take in fewer fats and carbohydrates, and you exercise more. How many people does that work for? And unfortunately, when you look at it on a longer range scale over 5 years, when we calculate how many people are able to lose a significant amount of weight and keep that weight off, it's less than 5%. So unfortunately, even with supervised weight loss, it's not highly successful. When you look at prescription medications, every drug company dreams about coming out with the newest weight loss medication. There's a lot of money in it. Obviously, people are willing to try taking a medication before they'll go to the lengths of having a surgery. And reasonably so, but unfortunately, most of those medications are something that decreases how much your body absorbs or increases how much your body burns, which is some derivative of a stimulant. Usually it started off with speed, and it's come to a lot of different medications that behave in that same way, usually ending up with cardiovascular consequences. As far as candidates for surgery, when we look past medical treatments, we get to the surgical weight loss, which again has been the only proven thing to provide sustained weight loss for people. And these are criteria that, again, we didn't come up with. They were put in place by the national organization. But a BMI greater than 35 with comorbidities, and again, that list plus the others that were not listed are qualifiers, or a BMI greater than 40 without one of those comorbidities. You obviously have to be able to undergo a major operation without side effects. You have to many times show failed attempts at medical weight loss, and a lot of that is determined by insurance companies. Unfortunately, they can dictate if you need to go see your physician for 3 months or 6 months and try a medical mandated weight loss program. Absence of drug and alcohol problems, and again, drugs would include nicotine or smoking. That's been shown to increase the complications from surgery, and quite honestly, I see it as one of those things that if we're doing this for our health, why not quit smoking? It's one of the most healthy moves or decisions that you can make. So in order to undergo the surgery safely, you have to be able to quit smoking. That doesn't mean that we turn anybody that is a current smoker away from the program. We still work with you and try to get you to the point where you're a non-smoker so we can proceed with surgery. No uncontrolled psychological conditions. Obviously, there has to be consensus by our multidisciplinary team, which includes the psychologists. You understand the surgery, its risks, its benefits, its alternatives, and that's why we're doing this tonight, so that you can really understand what the surgical options are, what the risks are, and then we're talking about the benefits here. And then obviously the bottom one is my favorite one. You have to be dedicated, and not just dedicated enough to quit smoking long enough to get to surgery or lose some weight and show that you're a good candidate for surgery. You have to be dedicated to lifelong changes in your lifestyle that will allow continued success after surgery. Fit Camp, again, I mentioned that earlier. It's an individual exercise evaluation. The exercise specialists take you to their gym and say, okay, do you have health problems already? Do you have a bad back? Do you have a bad shoulder, a bad hip, something that is not allowing you to do certain exercises? Not everybody can just put on some jogging shoes and go out and run for a while. So they work with you and say, okay, you know, do you have access to a pool? If you've got a bad back, that's a perfect way to unload some of the strain from your back until you're able to lose enough weight that your back is under less stress and you're able to do some other exercises. And then they really fit that to what you have available to you either at home or in your own gym. So it's a really great program, and I think they're still offering it to our patients. Pretty much it's dirt cheap compared to what a personal trainer would cost. So okay, perfect. Yeah, and the brochures are in your handouts, so that's something that I don't mandate, but I definitely tell people to look into and strongly encourage that. So John's one of our patients from probably 4 years ago now. He was pre-surgery, 2014, 306 pounds, BMI of 46.62. So that's kind of what that looks like on the left. And a year later at 202 pounds, he continued to have success. And I think he was in one of our ad campaigns on TV, if you recognize him from the commercials that played a year, maybe two ago. far as general insurance criteria, I will admit that I try to remove myself from all the insurance business. I let Karen and Vicki take care of that because I dislike insurance companies, quite honestly. So they cut through all of that red tape for us. Again, I'm happy to do whatever is needed for insurance negotiations, but a lot of them will require different things. Some of it may be visits to your doctor, some of it may be visits with our dietitian, the psychological evaluation, proven to be in an exercise program, and then previous attempts at weight loss that have failed. So depending on what insurance program you have, those criteria may vary. As far as surgical options, there's really a few different surgical options. Purely restrictive would be things like the adjustable gastric band. Some other examples I'm sure you guys have seen in the papers and magazines recently, where the intragastric balloons will restrict how much you're able to take in. Other surgical options, the sleeve gastrectomy is also a restrictive procedure, and it additionally has some benefits because it makes you less hungry. So satiety properties related to hormones like ghrelin and peptide YY, there's dozens of others that have been studied, but those are made in the portion of the stomach that is removed so that it has additional properties even over things like the duodenal switch and the Roux-en-Y gastric bypass, where the stomach doesn't remain intact, but it's left in. So the non-functional portion of the stomach continues to produce those hormones, and so you may not have that satiety or lack of hunger that the sleeve gastrectomy provides. And then combined restrictive and malabsorptive, the Roux-en-Y gastric bypass is the one that we would offer here. The duodenal switch, which I mentioned, is another option for that. And by rerouting the intestines, it decreases the amount of nutrients that your body's able to absorb. So again, we'll talk about some of the potential side effects of those types of surgeries as we go through. So the lap band or laparoscopic adjustable gastric band is a device where you fill, I'm trying to find if the pointer on this works, but you put a needle in this port here and fluid goes through and it squeezes down on the top portion of the stomach so that food is held in the upper portion of the stomach, or the small stomach pouch as they call it here. And I'll play a video that kind of shows how each of these surgeries works.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are placed through the trocars into the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. In preparation for the band, a tunnel is created behind the stomach. The Realize band is introduced to the abdomen through a trocar. The Realize band is positioned around the upper portion of the stomach and then secured using the locking mechanism. A tube attached to the Realize band will be connected to the injection port. The port is used to adjust the band tightness after surgery. An incision is made on the upper abdomen to insert the Realize injection port beneath the skin. The tube is secured using the locking connector on the port. The injection port and tube are placed beneath the skin. The Realize band does not alter your digestive function. Food consumed passes through the digestive tract in the normal route. Your surgeon may tighten the Realize band by injecting saline into the injection port. As the saline is introduced to the Realize injection port, it travels through the tube to the band. The addition of saline to the band creates a smaller upper stomach pouch. This smaller stomach pouch restricts the amount of food you can eat before feeling full. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
This slide just shows the anti-slip stitch that has been done. If you've heard about a slipped band in the past, that's something that early on when bands were placed, they were sliding up on the esophagus, or the stomach was sliding up through them and causing obstructions. So we started folding a leaflet of the stomach over top, suturing that in place to try to keep the band where it was initially placed so that we would not have slip problems. Now, it can still occur, but it's much less common than it was in the early stages. And then on the right, it just shows how much restriction as little as 2 milliliters or 2 cc's of fluid can make. So the sleeve gastrectomy is the next surgery, and it's a stapling procedure where we actually excise a long template to create a narrow stomach pouch from the esophagus down to the small intestine. It's currently the most common, most popular surgery because of the simplicity of it, as well as the weight loss in comparison to complication profile. When we look at things like the band and the Roux-en-Y. Certainly things like the duodenal switch have very, very high complication rates, and so we won't really discuss that here. We'll just kind of compare the three.
The sleeve gastrectomy is a restrictive procedure which limits the amount of food you can eat by reducing the size of your stomach. To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. Surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form, so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy.
And then the final surgical option that we offer here is the Roux-en-Y gastric bypass, or lap bypass, stomach bypass as it's commonly known. And again, it's something where we reroute the intestines, but this portion of the stomach is left in place so that the gastric fluid and the pancreatic and biliary fluid can go down and join with the intestine. Now, this limb here doesn't really allow much absorption or digestion, so that all takes place in this segment. So that's why with that shorter segment for digestion, you get some of the malabsorption, which adds to weight loss, but unfortunately provides some complications with vitamin and nutrient deficiencies that we have to watch for post-operatively.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested.
So this is a little bit busy, but it compares the three different operations, and down on the bottom is years after surgery. This is decrease in BMI, so everybody starts at 0 here. You can see the gastric band, and again, this drop here we don't typically see in a lot of patients. I'm not sure which study this came from, Chang back in 2014, but again, we see it in comparison to the to the sleeve gastrectomy and the Roux-en-Y, and those two are kind of mirror each other down here and level off again. Usually after about year 3 we see people start to level off and really maintain stable weight. So that's something that when you compare these, you can see that the difference in the amount of weight loss between the sleeve and the gastric band, as well as the long-term complications, are why the sleeve really overtook the band as being the most popular weight loss surgery. The Roux-en-Y has been around since the late 60s, and it's certainly it's the gold standard for weight loss operations, but because of the risk profile that goes along with all of those staple lines and putting things back together, as well as the long-term risks for vitamin nutrient deficiencies and internal hernias, it's become a lot less popular because you can see that the sleeve does almost as good a job as the bypass in terms of weight loss and maintaining weight loss. So with every surgery, we have to talk about what could go wrong, and acute complications are those things that we watch for in the operating room and right after the operation. So when you look at any operation, people will say there's the possibility for bleeding or hemorrhage, for blood clots, both in the legs and the ones that go to the lungs, for infection, and for the stapling surgeries, that could be either a staple line leak or a bowel injury. With the gastric band, bowel injury or stomach injury would be the ones that we would worry about there. And then for the band, you look at acute obstruction. Even when we do not fill the band at the time of surgery, there can be enough swelling around the band that it really blocks things off, and that can be significant enough that sometimes people just have to wait a few days before they're able to take anything in. They have to be on IV fluids during that time, but there have been cases where the band has had to be removed in order to overcome that obstruction. The sleeve gastrectomy, again, the staple line leak would be kind of unique to it when compared to the band. And then the bypass, we've got the same things, staple line leak and then anastomotic leak, which is where we put the intestine back together with the stomach. Heidi is another one of our patients. Pre-surgery, 2013, 247. She's 5'5", so she still had a BMI greater than 40. 2015 at 160 at 2 years post-op, and she's, I think, below that now the last time I talked to her. Heidi's been really great to the program in terms of showing how things will work. She's been in an ad that was run a couple of years ago as well, but it's really been neat for me. She's one of the several nurses now that I've operated on, and able to see on a day-to-day and week-to-week basis how this change occurs. And so it's been really great seeing Heidi, and it's really fun asking her, making her look at old pictures, because when she sees pictures of pre-surgery, she blushes and gets really sheepish and says, "I can't believe that I looked like that, and nobody told me that I looked like that." And so she's really done a great job, and really proud of what she's done. As far as long-term complications, again, when we talk about the band, that slipped band is something that can occur. Band erosion is something that we're seeing not infrequently with the number of band devices that have been placed up to 10 years ago. And that's where the band actually kind of erodes or ulcerates inside of the esophagus or stomach, and then causes an infection around it where it has to be emergently removed. Infections can occur, especially at that port site, if they're not accessed under sterile condition, and then they have to be removed or replaced. Mechanical failure, and that's something that wasn't really well described. The FDA only approved the band to be in for, I believe, 10 years when they initially approved it. They didn't really do a good job of making the companies that sold the band tell the surgeons that that was the case, and so everybody was told, well, these last forever. Unfortunately, we're seeing a lot of them now that have worn out and are having failure because of that. And then you'll see gallstones under all three of these categories. Again, that's a possible side effect of weight loss surgery, because it's a side effect of weight loss. And you'll see a lot of people, after they lose weight, after a pregnancy, get gallstones, for example. So between the hormonal changes and the weight loss, it provides the perfect setup for gallstones. So unfortunately, that's one of the side effects, but even if you lose weight without surgery, that's a side effect or a possible risk. As far as the Roux-en-Y, again, you see kind of the longer list of long-term problems that can happen. A stenosis is a narrowing of that connection between the stomach and the small intestine. So where we put it back together up on the pouch, if that narrows, then it can cause an obstruction later on. The problem being, if that happens, then there's not a lot of reconstruction options there to get people back to eating by mouth. Marginal ulcer is in that same area where the stomach and the small intestine are hooked together. You can form a stomach ulcer there that can cause bleeding or perforation. It's usually painful and something that is not terribly easy to fix if it's a blood flow issue. Now, I will be honest, most of the people I see with this have either started smoking after surgery or taking anti-inflammatories like ibuprofen or naproxen, but that's not always the case. Internal hernia, I think I mentioned briefly before, and that's when we reposition the intestines on the inside. There are times where they can cross and get twisted and cause bowel obstructions, and herniation on the inside requires an operation, sometimes emergently, to fix that so that the bowels don't become gangrenous. Dumping syndrome is exactly what it sounds like, unfortunately. With malabsorption, the body, if it takes in nutrient-rich foods, isn't able to absorb them, so the small intestine shuttles them through quickly. And so people that have that are typically looking for a bathroom if they eat nutrient-rich foods right away. So, and then vitamin deficiencies, again, some of them can be things like brittle nails and hair loss. Some of them can lead to permanent brain damage. So it's something that we watch for, and labs have to be drawn temporarily to make sure that the vitamin and nutrient levels are satisfactory after the operation. As far as the medical comorbidities, this is it's one of my favorite slides, just because when you look at things like osteoarthritis, you get bigger and your joints go bad, and then unfortunately, if it hurts to move, you do that less. And become more sedentary, and then things like diabetes and heart disease play into it, and things just continue to get worse, and it's kind of a downward spiral where one health problem piles on top of the next and may cause others. And when you have surgery, this process often reverses to the point where when the weight comes off, you're able to get off of your reflux medication, your cholesterol medication, your diabetes medications, and most people talk in terms of pounds lost for success, but my favorite patients and the people that I really like talking to in the clinic aren't talking about how many pounds they've lost. They're talking about how many pills they've lost, how many pill bottles they've thrown away. And that's always a neat conversation to have in terms of how this process has reversed and things get better from a health perspective. Scars after surgery. I tell people this is after an open gastric bypass. You can see where they attempted to do it laparoscopically, but that's a fairly fresh scar, I'd say probably within the first 3 months. You can see the staples that were in there, and that's a typical incision that we use for a lot of open abdominal surgeries. That will fade back to kind of a normal skin color and not be so prominent over time. But the laparoscopic ones are the ones that we normally see. And again, those may be more apparent. Most people have seen somebody or have had an operation like an appendectomy or a gallbladder taken out laparoscopically now. The scars are very similar to that. And so if you wonder what they would look like on you, that's very similar to what they would appear like. As far as post-operative care, for the gastric band, we have everybody in the squeezers, the leg sleeves that squeeze to prevent blood clots. They're on clear liquids post-operatively, stay overnight, and typically go home the first day after surgery. For the bypass and the sleeve gastrectomy, we keep people a little bit longer. The gastrographin is the yucky x-ray dye that you have to drink after the surgery. After you drink that, we take x-rays and watch it pass through that pouch to make sure it's not leaking out through the staple line and that it's not obstructed. The JP drain is a plus or a minus, and again, that's post-operative, day 1. Depending on how you do. I started doing that same day. The sleeve that I did this morning, for example, had hers done at 2:30 and is already doing clear liquids. So we're kind of speeding that up a little bit for some of the sleeve patients. But the drain, again, if we have any concerns, then we can place a drain, but I've kind of stopped doing that routinely. So SCDs, again, are this sleeves that go on your legs, on the calves, to squeeze and prevent blood clots. And we also give blood thinners prior to the operation and throughout the hospitalization to prevent blood clots. People always wonder, well, why would you give blood thinners right before surgery? But it's because the risk of blood clots is high enough that if we have some bleeding, typically we can deal with that in the operating room after the operation. A blood clot that goes to the lung could kill somebody, and we can't correct that fast enough, so we prevent it up front by giving blood thinners. After the swallow study, then we start our bariatric stage 1 diet, clear liquids, and then discharge on day 1, 2, or 3. I've had several people that do well enough that we're able to let them go home the day after surgery. I tell everybody to plan on staying 2 nights, however, because we don't ever know who's going to be slightly ahead of the curve, who's going to be average, and who might take an extra day to get comfortable enough to go home. As far as the post-procedural diet, that bariatric or clear liquid diet lasts for a week. After you get out of the hospital, we do add a protein source to that, so it's not strict clear liquids. But we're very adamant about how much fluid intake. One of the biggest problems that we worry about is dehydration. And it's something where after the operation, you're not able to take in, you can't grab a bottle of water when you're really thirsty and take a big drink of it. You have to take little sips all day long to stay hydrated right after surgery. After the first week, we go to full liquids, and then at the end of the second week, soft foods, and then progress to a regular diet. So usually when I'm seeing people at the 1 week post-op visit, they're kind of transitioning into that full liquid diet, and when I see them at the 1 month visit, they're past their soft foods and starting to try regular food again. And again, that's kind of variable for everybody in terms of when they're comfortable moving on to a normal diet. As far as follow-up care, again, I see everybody while they're in the hospital, see them at 1 week approximately after the operation, 1 month, 3 months, 6 months, and a year, and then I try to get everybody to come back at least yearly after their operation. There's data now showing that people that do that have better sustained weight loss than people that just have surgery and go try to do it on their own. And most of my patients that are coming in, some of them want to come every 3 months even because they've got problems with depression or kind of fall off the wagon in terms of exercise, and they like to come in and sit down and talk about what may be going on, get on the same scale, and really hold themselves accountable. And that prevents backslides better than anything that we can do long term. So, and then the band, again, if that's placed, you have to come in at regular intervals and have small amounts of saline added to that band until we can titrate it to that perfect level and make sure that it's just right so that the restriction's there, but you're not obstructed so that you're throwing up or irping all the time. And then again, we always maintain ongoing clinical or communication with our clinical team so that if somebody is having some weight gain they're concerned about and we can't really put our finger on it, we can have them go talk to Sealy, for example. I've seen people that were just racking their brain to figure out why they were gaining weight. I'm not eating anything, and I don't know what's going on. They'd keep a food diary and bring it in, and it turns out that lattes were their big thing, and they'd never had considered that lattes have a lot of calories. And this was before Starbucks was posting it, so coffee was coffee in their mind, and they were taking in 1,000 calories worth of coffee a day. So that's something that, again, we're able to kind of tease out through different people in our clinical team, figure out if there's a problem, how to fix it. As far as support, again, the support group is something that I strongly recommend. It meets, conference room A now instead of here, but it's on the first Thursday, 6:30 to 7:30 every month, and it's great. I do not show up. I found out that there's a lot of things that are shared among patients if the surgeon's not there. So it's something that you'd like to think that everybody is level and honest with you when they come in and talk to you in the office, but there's a lot of things discussed in support group, concerns that people have, things that have worked for them, even things like recipes and exercise regimens. So it's something that is very helpful for everybody, whether they're thinking about surgery, have a family member, a loved one that's going through the process, if they've had surgery a long time ago and just want to get back into the program, or like you all are looking at the program today. So this is Jan, and again, pre-surgery in 2014 at 325 for a BMI of 52, and in 2016, 2 years later, down to 223, over 100 pounds. And one thing I like about Jan is, I can't remember, I wouldn't say how old she was, but Heidi's a little bit younger, so some of our older patients look at her and say, of course she was able to lose weight. But we've got several patients now that are over the age of 60 that have lost over 100 pounds, and doing very well after surgery. So it's something that anybody can do if they meet the criteria for surgery. Insurance notes, and again, I should just let Vicki read this because, again, they call the insurance company, verify coverage, get the list of criteria for your specific program and plan. It's different for everybody, as I've said. The one thing I will say is that the hospital here has been wonderful in supporting our program. It's one of the great things about having a small community hospital. They will put out a financial plan that is unprecedented and really unparalleled by any other hospital that I've seen, to the point where I've done a gastric bypass on a lady from Scotts Bluff. Her daughter had had a gastric bypass in Scotts Bluff, but the mother's plan did not cover the same surgery, and our financial plan allowed her to come here, have surgery, and so they're going through that process together, even though they didn't have their surgery done in the same town. So, and then she'll discuss that with you in detail at you all's visit. I don't have the answers for that stuff, but again, I'll do anything I can to help with the process, but they do a great job of teasing out the details of that and getting people approved. So again, I hope that we've provided enough information to prove that surgery is something worth considering. It really can change your life. If you can lose weight and keep weight off without surgery, if we can find a way to help with that, I implore you to do that. But unfortunately, the facts don't really support that for the majority of people. So that's why we're here tonight talking about surgery. So it's a tool. It's something that will provide weight loss, but it requires a lot of support from you beforehand. Again, it's not something where you call Vicki, she calls your insurance, you get approved, you come see me and set up a date. It's not that easy. There's a lot of hoops that people have to jump through, and that's so that we know that you're a good candidate. We've got a reputation. We're very proud of our program here. We want to make sure that we provide the service to people that are very serious about improving their health. Likewise, we want to make sure that everybody is committed to that lifestyle change and the long-term goals. This isn't something where we do it to get in a bathing suit next summer. That's not why we do surgery. We're doing it to make people healthier and really giving people a second lease on life. So, and then this is the contact information for Karen and Vicki. They're kind of the point people to touch, or the contact people for the program. Again, they from the time of insurance approval to your appointment kind of direct you where to go next in the program and in the process.